Hi, Jasmine. Oh, that's awesome. School starts next week. Oh, I'm excited for you. That's awesome. Hi, Shanice. Hi, April. Thank you all for joining me. So, I'm doing a live again tonight. It's okay. I don't think y'all mind. Y'all seem to like these lives anyway. So, I'm going to talk about a few things tonight. I have about an hour with you all. So, whatever you want to ask is totally fine. Just make sure it's not anything basic like how do I get started? What school do you recommend? Because I've talked about like the school recommendations before and it's the same. So I am going to talk about two things though. One is about self talk, like how you talk to yourself about what you're doing with coding and learning it. And the other thing is about the alternative jobs that are going to get you some experience. Because sometimes people want to get into these off the wall type things like being a scribe, and that doesn't really get you the experience. So we're going to talk about that too. All right. Hi, Michelle. Hi, Letty. Doing great. Oh, I know. I'm sorry. I'm sorry. I don't mean to have it as Blue Standard Time, right? But yeah, I'm here. And I'm glad you all are here. We'll just leave it at that. Hi, Alexandria. Yes, oh, good. I'm so glad, Jasmine. Hi, Nicole. Uh, do you have any basic medical billing videos? No, my channel is called Medical Coding with Blue, not medical billing. Hi, Britt. Uh, hi, Carrie. Mm. So let's talk about the freak out message that I got from somebody the other day. Okay, here's the other thing too. You all have to know this about me by now. I am very blunt. And I hurt feelings, apparently, because you can't be blunt without hurting feelings, apparently. So here's the thing. When somebody tells me, oh my gosh, I'm so scared and I'm going to take my test on the 28th and I'm going to throw up and I just don't know what to do. I forgot everything. I just know I'm going to fail. I'm doomed. Okay, doomed. All right. And I said that if you have that kind of attitude, then absolutely you will fail. 0 to fail in 2.2 seconds. 0 to fail. Because you're already saying that. So here's the thing I always say. If you are studying like you are supposed to, you're not going to have this dramatic reaction of, oh my God, I'm going to fail. Why would you have that attitude if you've been studying for 20 hours per week? Now, if you haven't, then you get the score that you deserve. And you have no right to come on my channel and say, oh my gosh, I'm so scared. Because as this other lady said, when I posted it onto LinkedIn, I'm like, don't do this. This is what you do not do. You do not say things like this because you will be 0 to fail in 2.2 seconds. Completely. You need to turn around that thinking. Now, I say that as a learning opportunity. Of course, somebody takes it as, oh, I've got to stand up for these people that they're extra sensitive. So this lady comes on there and says, well, Blue, sometimes people need to vent. Okay, there's venting and then there's putting out that energy and other people see it. And when other people see it, then they start to panic too. And I know for a fact that people on my channel look at the comments because I've been told about my responses to some of these people too. And I've seen people go after other people too in the comments for the things that they've said about me. So with that said, I know that people look at those comments and they pay close attention. So I don't want somebody to see this as it's okay to have this freak out and I'm going to be all coddling and say, oh no, it's going to be okay. No, I'm going to tell you, okay, how much did you study? And if you're going to keep thinking like that, then absolutely you're going to fail because that's not you don't need to be having that kind of reaction if you've been doing what you're supposed to do. And now if you're trying to get in because you want to have everything your way, you want to have a high salary right out of the gate, like stupid people do, because who wants a high salary right out of the gate when you have no experience, you have no idea what you're doing? You work up to it. And it doesn't take very long to work up to a good salary and a high salary for those who really dedicate themselves to learning. But there's people that want it right out of the gate, or they come over from like the nursing side, for example, and they want the same pay as they get as a nurse. Okay, let me tell you something. When you are a nurse, you are responsible for other people's lives, right? Because if you do something and you screw up an injection, you could end somebody, right? In medical coding, we don't have that. Our stuff is on the data side, the technical side, the financial side. That's what we have. So the risk is a little bit lower. Now, here's the thing. You're coming in with this attitude of, oh, okay, well, I'm a nurse and I can make all this high salary and that's what I want to do medical coding for. Instead of working your way up like everybody else, because that's what happens. And having a little bit of patience to be able to do that so that you can actually get somewhere. But no, there's been people, oh, well, thank you for the advice, Blue, but I think I'm not going to do this because of the low salary and all this good stuff. Okay, well, low salary, then you don't need to be in it anyway because it's not low salary. And if you are having low salary and you have experience and you have the knowledge, then obviously you need to go someplace else, right? Because a lot of times people will find themselves in these low wage paying salaries because they work for a doctor's office. Well, an independent doctor's office is going to have a different financial situation. They're going to have it where they're going to have to watch every dollar. And instead of paying appropriately, they're going to try to keep that money as tight as they can, so they're not going to pay their staff, or they're going to pay their staff barely minimum wage or barely just above minimum wage. So that's why I tell y'all to stay out of those doctor's offices. But again, if that's where you're at and then you have the nerve to complain because the pay is so low, then you need to look elsewhere then, right? I'm just saying. So, I do very well. And for the longest time, even with just a CCA, I outpaced salary-wise people who had degrees and who were nurses. So I don't want to hear it. You know what I'm saying? I don't, because it's possible to do very well in this field. But if you're automatically looking at that, like that's your starting salary, that's where you're going to stay at, well, then again, you get what you deserve. So for those of you, to go back to the main point, if you're going to insist that you're going to fail because you're a nervous test taker and you're doomed, that's exactly what's going to happen. Instead of having the opposite reaction, which is the rational one, which is I've been studying, I've been putting in 20 hours per week, I've been getting the rest like I'm supposed to, I've been actually practicing looking up the codes and not looking at multiple choice. I'm actually going through and working through the problems so that I can critically understand what's happening and how to get to the answer on my own, again, without having multiple choice. I have more confidence that way. I've been studying medical terminology and anatomy. I know everything about reimbursement. I know everything about, all of these laws with HIPAA and the OIG. And I've been doing what I'm supposed to. So I'm going to go in there and I'm going to give it my best shot. And I'm going to do what I need to do to prepare myself and rest and take a couple of days off before I go in and take that test. Because at the end of the day, it is just a test. It is just a test. It is a competency test. There is no reason at all to be having this hysterical reaction of, oh my God, I'm going to fail. If you say that, that's exactly what's going to happen, because your brain is like, okay, then we're going to fail then, because that's what we think. That's what we say. And it's not about being delusional. It's about actually putting in the work so that you can be confident enough that I know what I'm doing. I know what I'm doing with the coding. In the year that I took the CCSP and the CCS, I took them both in the same year. And the first one with the CCSP, which is the first one that I took, it was no big deal. I just basically didn't really do a whole lot of study because I had already been in the industry for 13 years. I needed to get the CCSP because I have other stuff going on in the back. And so I said, okay, well, I'll go ahead and get the CCSP. So I went ahead and got that. The real test for me was going to be the CCS, because that is the gold standard. That is the mastery of the inpatient coding and outpatient coding. And so I said to myself, I can do this. Every single time I'm studying, I always tell myself, I can do this, I can do this, I can do this. Is there always a possibility that something adverse could happen and maybe you fail? Absolutely. But for me, I'm not going to allow that negative thinking to get into my head. I'm not going to sit here and tell everybody, oh, I'm going to fail, I'm going to fail. I'm not going to proclaim it out into the universe that I'm going to fail. I won't do it, because that's a waste of time, and it's a waste of energy, and it's unnecessary worry. And for what? Who is that going to help? Who is it going to serve? Certainly not you, because it's going to keep you from your dreams. It's going to keep you from reaching your potential. And you may have somebody around you who is supposed to be loving towards you, but maybe they don't support you. Maybe it's a partner, maybe it's a parent, maybe it's a sibling, and they're not, as supportive as they could be. And you think to yourself, gosh, if they could just believe it, it doesn't matter what they think. Is it fantastic if you have a supportive parent, a supportive sibling, a supportive loved one? Absolutely. But it's not everything. Because at the end of the day, all you have to look at is yourself. To say, you know what? I put in the time. I put in the work. I am doing this because I want a better career. I don't want to stand on my feet all day and clean houses. I don't want to stand on my feet all day and, like me, cleaning houses, working at a bar where there's drunk people who can talk to you whatever way they want to, and you can't really get mad at them because they're drunk. And you do it because you need the money. And so, but it's tiring work. It's exhausting work. It does a lot to you mentally, because you have to put up with this. Not only that, you got to watch your back. You got to lift heavy bottles. You got to lift, cases of, beer and water and, all these things. You got to do all of these things, and you still have to maintain a smile on your face. Some of the toughest people that you'll ever meet are bartenders. Some of the toughest people you ever meet. But you do it because it's what you have to do to get yourself going, to put food on the table, to pay your bills, to be able to do all of these things that you have to do to be able to survive. And so when you think to yourself, because you have all of these external things like negative towards you, right? Like, oh, maybe a bad school that you went to, not a supportive teacher, not somebody who could help you to learn. You had to learn by yourself. So you have all of these external things that are going against you already. Don't be one more person that's going to be against yourself. That is stupid. That is really stupid. And if you allow yourself to get like that, no one can help you. I can't help you. No one can help you, because that's what you believe. Instead of believing in yourself that, yes, you can do this. Yes, maybe this is your life right now, that you're working at a minimum wage job, that you're getting mistreated at work, and that people are mean to you, or maybe they say things that are not polite, and you have to just put up with it. But it's not forever. That's what you can remind yourself. This is not forever. I'm going to get this test. I'm going to pass this test, and I'm going to do this. I have every right to pass this test like everybody else who has been studying. And start believing in yourself like that. Instead of this garbage of, oh my gosh, I'm so doomed. Just so dramatic. I can't stand it. It's just like, why would you do that to yourself? So again, lady who had to, of course, go and defend, she got blocked too. Because you know what? No, this is why people are weak. Because they do this. They coddle people. That's coddling. When you see somebody, oh my gosh, I'm so doomed. Oh, honey, it's okay. Oh, you just want to be just comforted and listened to. Absolutely not. Absolutely not. And they knew better. Anybody who watches my channel for more than one episode, you know better. You know better. And I say these things because I actually do care. Believe it or not, I do care. And what did I say a few lives ago where, you know how the kids, you tell them, don't touch the hot stove. And you keep telling the kid, don't touch the hot stove, don't touch the hot stove. And the kid wants to push and try things. And, he. They think it's funny because you're telling them, don't touch the stove, honey. Don't touch the stove. But you're saying it so sweetly, so nicely. And then the kid touches the stove and then they hurt themselves. And you're like, oh my gosh, oh no, sweetie, oh no. Instead of saying, okay, let me scare them so that they don't touch the stove. and they save themselves from pain. And if you say, don't touch the devil's hand, and they're like, oh my gosh, it's the devil, it's going to be hot, I'm not going to touch it because it's going to hurt me. Now you've got that kid, okay, they're going to critically think, okay, this person told me that this thing is going to hurt me, but not in a way that's going to make it so where I am going to want to hurt myself, right? By touching this hot stove, I'm going to make sure that I protect myself and be like, okay, I'm not going to do it because it's the devil's hand, you know? I mean, it's just stuff like that, you know, like just to me, that's just common sense, because I would never be like, oh, sweetie, don't do that. Because, you know, that's exactly what the kid's going to do. Okay, I'm going to do it. Just saying, you know. Oh, thank you, Candace. Candace says happy belated birthday. Oh, thank you. I appreciate that. Yes, my birthday was this month. Alexandria says everyone is too sensitive. Yes, I took a pay cut on my first coding job. I didn't expect things to be handed to me or others. There you go. Thank you, Angela. T says, good evening, Blue. It's Daphne from New Hampshire. I hope you had a great day. I did. Thank you. Is your Patreon link not working? Okay, never mind. I got it. Okay, good. Sweet Face says, you're amazing. I want to start, but so scared not to find work. Why you're not even starting yet, and you're already scared about not finding a job? No. You have to just concentrate on one thing at a time. Start with the school. Don't worry about the job. You know, I had this one lady. She worried about everything. Like the whole time I'm tutoring her, because she had booked me for tutoring, and this was like all these tutoring sessions, and the whole time she's saying, "What if I don't get along with my coworkers?" Ma'am, you haven't even taken your test. You don't even know which test you want to take yet, and you're worried about some imaginary person? Oh, Blue, I just want to be prepared. You know, there's going to be people that, no matter how sweet and nice you are, no matter how much you care for people, no matter how much love you show to people, there will be people that just don't like you. And it's nothing to do with you, because you could be the best, nice, most sweetest person ever, and you will still have people that just don't like you. They don't like you for the stupidest reasons. The way you look, your vehicle, maybe because you have a boyfriend or a girlfriend, or you have no children, or you have 500 children and they want children, or they like little babies, or whatever the case may be. They will find reasons not to like you. Oh, Blue, you don't wear the same things twice. I don't like you. For clothes? And you don't see me wear things twice? Really? That's because I know how to mix and match things. That's because I have staple pieces that can go with a lot of different outfits. So there's just some, again, don't worry about stuff that's far down the line, because that's what stops you from even trying to do anything. I'm so concerned about not being able to find a job. Haven't even been in school yet. Haven't even gotten a certification yet. But you're worried about down the road with your job. If you are doing what you're supposed to be doing, which is you have it in your heart, right? However it came to you, you have it in your heart to start this career field. Okay, so then go with it. What is the first step? You get into school. You find yourself a good school. And even if you find a school that you say, well, Blue, this was cheap, and this was all I could afford. Okay, then you need to supplement, because that cheap program is not going to cover it. Okay. Oh, well, they include the test, and it's a no-name test, but it'll get me started. No, it won't. No, it won't. That's why I have the independent study link for free all over my channel. The original, who did it? The original, right here. Who did it? Who put it together? Who has all the books you need, the syllabus, the time broken down, and all of these things. And it's literally the template. I've actually put it in every description box. Over the last 3 months, it's in every description box. The whole breakdown is there. So you have the opportunity to be able to do that. So you get into that and you study, and you find your way. You do your 20 hours per week all through the program, or all through your self-study. Then you get yourself in there. You take your test in 9 months, 12 months, or 18 months. And then you start looking out there. Blue, I've never worked in the medical field before, so I don't know. I don't have any transferable experience, which brings me to my next point for tonight. If you have worked in any industry, okay, I came over from housekeeping, I came over from bartending, and you may think, how in the heck does that translate? How did you put anything on there? Well, you put all your training down, number one, on your skills. You put your ICD-10-CM, CPT, HCPCS, ICD-10 PCS if you had that, medical terminology, anatomy, pathophysiology, because that's all on the job listing. You do not put team player, organized, smiling face. You do not put that on your skills list, because I would reject you simply for wasting my time, because you don't know the assignment. These skills are your hard skills. It is not your soft skills, which is that you're a team player and you're organized. That's what you save for your cover letter, which is not a regurgitation of your resume. That's going to be the human draw. That's going to be like, okay, this is where I'm coming from. This is what I have to offer you. I look forward to speaking with you. Not, oh, if you want to message me, here's my contact info. Why are you giving them a choice? You can actually get started in this field without having experience. What it is about is on your resume, in this one page, that you're going to say all the things that you have to bring over to these people. And if you don't know how to do that, there's lots of tip videos that I have on my channel about resumes and the best way to set yours up if you don't want to pay for it to be redone. There's a ton of resume writers out there on LinkedIn. I'm a resume writer myself. And I will never guarantee my resumes, but what I will say is that I've had a lot of clients that are successful with the resumes that I've given them, that they put out into, looking for jobs. But of course, you always have people, oh, well, I want to change this, change that. That's the one thing that I will tell people right out of the gate too. There's a 7-day turnaround for these resumes, because I'm a writer. I cannot perform like that. Yes, there's things that come to me like in my head, and sometimes some are faster than others. We meet for 30 minutes so we can talk about your needs. And then I wait sometimes to think about, what did you tell me? What can I put on this resume? How can I make this unique and for this individual? And that's what I do. And so when I'm speaking to you, we're getting all of these things out. I don't allow for revisions on my work, because you're coming to me. I'm the professional, not you. You're the one who needs the help. And I'm going to give it to you, but you need to let me give it to you the way I'm going to give it to you. That's what you pay me for. So that when you send the resume out there, it's going to be the voice of somebody that knows how to speak to other medical professionals for medical coding, health information, which is different than the people who are just your blanket resume writers who can do any profession. I can do any profession because I've not only done medical coding, I've done other professions as well. But it's about paying attention. What does the industry require? What do they need? So that's something else that you got to understand. But it's that these things are in steps, and you don't skip these steps. If you're in school, don't be worrying about your resume. If you're in school, don't be worrying about trying to find your first job in coding. Okay? You need to worry about one thing at a time, because if you allow too many things in front of you, it's going to overwhelm you, and that's when we stop. That's my advice anyway. Let's see. All right. But want to try to kind of in limbo. Shamika says, you will certainly be able to find a job in the coding career. There you go. Claire says, yay, Blue. Very true. Can only control you. There you go. Sweet says, I get you. Trust me, but hard not to worry when you have to invest money. I don't want to throw it down the drain, but I do get your perspective. Turned 40, been over 15 years not in school, and medical terms are so hard. Again, but I'm slowly getting into it, and you're right. I appreciate it. But see, you say that it's a big investment up front. You have to invest money up front. Well, if you're going to school, yeah. But as I've said, you can actually check out the books that I recommend that are in the description box of my regular videos, and they're at the public library, or you can order them online. You don't have to order everything at one time. This one lady, she said that she got all of her books, everything that I had suggested, she got all of those books for $284, and they were the 2024 editions. And that's what she's learning on. And then the updated ICD-10 CM guidelines that you can find on CMS for free, it's all there. So she's learning for $284, and she's going to follow my my self-study. So to me, that's just, again, it's another excuse, and it's people not knowing that that's possible because they think that they have to go through a school. No, you don't. Well, will employers be concerned that I didn't go through a school? No. All they care about is, do you have a certification and is it valid? That's all they care about. You know? Shamika says, what are some advice to becoming a better medical coder once you're working in the field? So whatever specialty that you're in, like say for instance, you go into ortho, right? You go into ortho, then you need to be reviewing the orthopedic guidelines for the musculoskeletal section, for the injuries, for the external cause codes, right? You need to know those forward and backward. You need to be practicing. You need to look up websites that are dedicated, like orthoinfo.org. You need to look at those types of websites, not an ad for them, but it just has a lot of information about orthopedics and the understanding of these fractures. Because when I see somebody, the patient has a both bone forearm fracture. And I've actually seen coders think that this is both bones, left and right forearm fracture. No, there's two bones here in your forearm. There's the radius and the ulna. That's what they mean. If you don't understand that, that's a problem. That's why I say, if you are trying to look at these websites that are dedicated to helping you to understand the pathophysiology and the physiology of these diseases, then you'll be all right. And it's not just those. There's going on crash course on YouTube, right? They're wonderful for medical terminology, anatomy, and pathophysiology, free 10-minute videos, 8-minute videos. I think their longest is like 15 minutes. And then they have like a whole playlist. So you're going through those things and you're not skimping on the details of your specialty. So you see, I know orthopedics forward and backward because of the simple fact that in 2014, when we started learning about ICD-10, because we were implementing it in October of 2015, we were going through a program at work. Well, I was very fortunate to be able to be going through a program at home as well. So when I'm going through the program at work for ICD-10 and I'm coming to the program at home, and I'm paying attention to the program here at home, I'm getting double the training. So whatever my work was missing out on, I could pick it up here at home. So I was getting double the training. So that was helping me to really understand injuries, which made sequela not an issue for me, which made understanding external cause codes not an issue for me, which meant that I understood when initial, subsequent, and sequela, when all of these applied. And it helped me to better understand these things. So because I was able to do that, that helped me to better understand. And I was able to become a better coder because of it. Not only that, there's also a little bit of moxie you got to have, because at that time, it's not just us as coders that's learning, it's our providers that are learning. And they know that this is important. And at the time, I was very nervous about talking to the providers, because at the time, I thought, okay, well, they're doctors. What could I possibly teach them that they don't already know? And so I had this one doctor that he said, Blue, you're the coder. I don't understand this stuff, and I need your help to help me to understand. I said, oh, you're right. He goes, I know the doctor stuff. I know surgeries all day long. He goes, but I don't know anything, things about coding. And I said, okay. He goes, but I understand you when you're trying to explain it to us. And I know how to explain it to the other doctors so that they understand, because doctors understand doctor, right? And coders understand coder, because I've been told, hey, Blue, you're speaking coder, because they don't understand. So I have to break it down in simpler terms for them. And it is the same thing that they go through as doctors. Well, this doctor was like, okay, well, if we can work together, I can help, and I'm like, well, okay. And we made a good team. He used to say that all the time. It would embarrass me as much as he would say it. He's like, Blue, we make a good team. And I'm like, oh my gosh. But he was right. I know the coding side, and he knew the doctor side. So because of that, I would pick his brain sometimes. I'd be like, okay, I know this says this, but why is this way? And he's like, oh, I can explain this. So he starts explaining it. And I was like, oh, okay. Because like I didn't know why they because he would put in his documentation that something about antibiotics, that if they needed to take any antibiotics, that that to let whoever know that they had a knee replacement or some other replacement, hip replacement or shoulder replacement. And I asked him one day, I said, why do you say this in your documentation? Like if they have another surgery within a year, that they have to tell them that they've had a joint replacement. And he's like, well, there's an increased risk for infection because they've already been opened up, and it's just, there's just a higher, and he broke it down and explained it. I said, oh, now I know why they do that, So, but it's true, or like if they're having dental work done, it was the dental work. And so I said, well, that makes sense. That makes a lot of sense now. So I was able to understand only because I made that effort and he made that effort. But he almost didn't make that effort because he actually complained about me. This was what kind of started the whole thing too. He complained because there was a hospital administrator that came by, and he was a liaison. His duty was to be a liaison between the staff and the providers, because they wanted to make sure that the providers were happy. So his job was to go around and talk to all these providers and ask them, what is it that they need? What do they want? What can help them to do their job better? And so he sat down one day in this doctor's office, and he's like, well, what can I do? How can we help you? And he's like, well, I don't get any feedback from the coder, which was a freaking bold-faced lie, because yes, I did give him feedback, but he wanted it in person. He says, well, he says that you don't talk to him. And I said, what? And he's like, yeah. He's like, you said you don't talk to him, and that you just you only send him emails. And I go, he's like, well, he says he would like for you to have more feedback in person. I said, oh, really? He did he? And he's like, well, yeah, And he kept trying to talk, and I was like, you know what? I'll be right back. He's like, wait, where are you going? And I was like, I will be right back. So I went right over there, and I knocked on his door, and he's like, oh, hey, he's all looking at me, and he's like all smiling. And I said, so I hear from a little birdie that we have a problem with our communication. He's like, well, and I said, why didn't you just tell me? I said, I've even told you in the emails that if you need any advice, you need any help, let me know, and I will be right over. He goes, I don't like email, Blue. You couldn't tell me this? You couldn't tell me you don't like email? We pass each other in the hallway, bro. I see you. We say good morning, hello. You can't tell me, hey, Blue, I have a question. He's like, well, and I said, and your work is impeccable. It's like reading poetry. And he starts laughing. He's like, Blue. And I was like, it's true. And I go, so what is it that you want me to do? You want me to find stuff that's wrong with your notes? He's like, I just want to be able to improve. I said, okay. I said, but you need to come talk to me. Don't tell other people. I said, because that's not right. And he's like, well, I didn't know. Well, now you do, so that worked, and I was able to learn from him. I as much long story short, I learned a lot from that man, but he also learned a lot from me too. And so that's something that you have to be willing to put yourself out there in order to do. Because I could have taken that administrator's word and been like, you know what? mess on that guy. I'm not gonna deal with him because he clearly lied. He didn't tell the truth. He didn't say that yes, she's been writing me, she's been querying me and says that I'm doing good. But I want more. He never said that. But it all goes back to, again, these doctors, they spent so much time in school being a nerd, being a nerd with the books. They didn't party in college. They were trying to get into medical school. When they're in medical school, it's just about getting to being a doctor, And so because of all of this, their social skills are stunted. Okay, so you have to take that into consideration too. To be a good coder, you have to be willing to make the first step. And if it means asking them a question because you don't know what this is or whatever it is, then you need to go and ask. You need to be there. And this is the thing for my remote coders, is that if you're in the area and like the hospital is a short drive from your house, you need to be there. You need to be saying, hey guys, I'm just here. I just want to say hello, and show your face, because people who don't show their face in the clinic and they want to hide behind the computer, and the provider gets mad and the provider yelled at me and they gave me an attitude because they don't know you and you're trying to correct them. Unlike the person who has the relationship already with them, and to say, hey, I noticed on this note here, there's a little issue here. Not, oh, I'm sorry to bother you. But I just wanted to, no. Excuse me, sir. Do you have a minute? I need to bring something to your attention. Okay, what is it? This, and this. Perfect. Right to the point. And that's how you start to build your skill as a medical coder. That's how you start getting better as a medical coder. Also, attending conference. Y'all think I'm playing when I tell y'all to attend conference. Conference is very important to attend. In-person conference, in-person meetings. Because not only are you getting the material for whatever it is that you're learning, but you're also hearing those questions from the people in the audience, or you're hearing that feedback from whoever is listening, that this, and this. And it gives you ideas. When I spoke last year in Salt Lake City, and I was talking about my approaches to provider education, this was a novel idea that a lot of these people had never even thought of before. And so they were like, oh my gosh, Bleu, I'm going to try your approach. Well, do you know, I heard from people afterward that said that they tried it and they were successful. So that's what you learn being a coder, and you go and you invest in those opportunities to learn more. Does that get expensive? Yes. But that's why I say I have those savings trackers now, okay, for your membership, for the conference ticket, right? Because I did one for the conference tickets. The savings goal is $900, because if you go to AHIMA's conference this year, which is in October, the 12th through the 14th, I believe, up in Minnesota, Minneapolis, Minnesota, that's where they have it this year. But if you go and you attend over there, there's all the things you're going to be able to learn while you're there. Okay. And it's not just limited to one subject. It is all subjects, and you're listening and you're meeting people and you're going and you're, touching base with the vendors and things like that. And sometimes it's just a matter of making those connections. That's how you make connections again. And then you start building your network. Well, when you have a good network that you can rely on, that means that you're never going to be without. For me, I have a fantastic network of incredibly intelligent people, like my friend Jessica, who used to be my supervisor. But I know I can go to Jessica at any time I get really stuck, because you always want to reach out to somebody who is as smart as you or smarter than you. You never want to go to somebody who doesn't know as much as you do. Jessica knows everything. She says, oh no, Bleu, I know I don't. I said, yes, you do. Like, she will recall like coding clinic and CPT assistant. Like, she'll know, hey, I remember something from there. And I'm like, that is, even I read it a lot and I still be like, I have to think. But she has like that good photographic memory. She can remember things. And so it's really awesome to have somebody like that I can back up to, be like, okay, well, what do you think about this? No, it's this and this, or there's this reference. And she'll do the same for me. She'll be like, hey, what about this? Because she knows I know all about injuries. And I said, okay, and I'll explain it to her. So there's always that. That's how you start to build those connections and become a better medical coder. If you're not doing those things, you're limiting yourself. I'm just saying. All right. Yes, Britt. The only thing to fear is fear itself. Hi, Crystal. Shamika says, hi, Blue. You redid my resume and cover letter for me, and I got a coding job within 4 months. You see? So I'm just saying. And I have been working as a coder ever since then. Yay! That's awesome. I am so happy for you. April says, I love the self-study program you put together. Oh, good. Claire says, hang in there. Hang out with the orthosurgeons. Yes. Yes. Watch operations. Yes. You can watch operations on YouTube as well. For any surgery you want to see, you put in the name of that surgery, and you will see a lot of surgeries come up. That was how I learned about meniscus surgeries, because I struggled with meniscus surgeries. But after I started watching them, trust me, it's a game changer, you know. I'm just saying. And let's see. Joy says, hi, Ms. Blue. My teacher sent us a link to some of your videos. You are very helpful. Thank you. I am doing my medical course through my state scholarship. Oh, good. Maybe they can check their state resources. Yes, that was how I got my medical coding education paid for too, was I went through the state. I went through the it was the WIA at the time. Now it's the WIOA. You can Google that and see if you qualify. But yes, there's funds out there for it. Emily says, hey, Blue, I'm raking my CCA, taking my CCA in March. I studied with the AHIMA study guide and the one from Amazon that was in your link. Is there anything else that you would recommend? Love your videos. Thank you. Mingo says, newbie here. Love this channel. I literally work for an ortho. What a mess. Ortho bros. I'm just saying. Ortho bros and ortho coders are a different breed. Yeah, we'll have to say that. Made me want to get certified in coding. Even had to do the billing deposit. Have you guys done a billing deposit? Billing disposition? I don't do billing. So the third party handles the billing. I just do the coding. I've only done the coding. So it doesn't mean that I don't know about the billing, but as far as my functions at work, I only do the coding, which is fine with me, you know. Crystal, I'm dying over here, Blue. Miscommunication is the biggest issue that can be simply resolved by talking to each other. Yes, exactly. And thank you, Shamika. I appreciate your kind words. That is so nice to hear. Now, let's see. Emily says, is there any other books that you recommend? So I don't see that you talked about the CPC study guide. So the CPC study guide, even though you're taking the CCA, the CPC study guide covers all of outpatient coding, all of the CPT coding. And that is the best book for practice. It doesn't matter that it doesn't say CCA. You're just using it to practice the CPT coding. They have scenarios, they break it down, they give you all of the answers. They don't do this odd answer questions only, odd answers for the questions. They don't do that. That they answer everything, and they give you simple explanations. And that's what I think AAPC did a fantastic job. I'm not with AAPC in any way, but I will promote things that are good for coders. Any books that I find that are excellent for coders to learn, absolutely. I will talk about those. And that is the one thing I have suggested to people, even though they don't understand, because they're like, but it says CPC. I'm not telling you to take the CPC. I'm telling you to use the practice in that book. You know, I'm just saying. So, but yes, so that's what you want to do. But let me talk about, what is it? optician and scribe. So opticians, I've done resumes for a few opticians, and some of them say that they've had exposure to codes because they select the codes. That's not the same as coding, but you're just getting exposure to codes. The good thing about being a optician is that you have exposure to the electronic health record and that you may select those codes. But you're not going to say that you're doing coding, because that's not coding. That is selecting from a super bill or selecting from a pre-approved list of the stuff that they already do at that clinic. So you want to make sure that you're very clear about that. So this one lady says, well, I'm going to be an optician. Is that a good job to get into medical coding? And I said, well, not really, if you're not, I mean, because there's very limited exposure to codes and things like that. And she says, oh, well, well, I'm doing the billing too. They said I could do billing too. So when you are having to wear more than one hat, right? So not only do you, as an optician, do you have to take care of patients and do patient care, but now you're also probably doing the prior authorizations. You're probably also submitting the bills, because she said that they do the billing as well. So you're having to do those billings. If it gets denied, it's going to come back to you, and then you're going to do whatever you do with it if you have to go and correct it. And then you have to go back to your optician duties. Does that seem fair to you if you're doing all of these jobs? Billing, the optician, and doing any sort of other administrative duties, because you're not doing coding. So, she may say, oh, ha, which I thought was kind of stupid, but whatever, why are you laughing? You're the one who wants to get into coding. To me, there's very limited, but it is something to work with, but it's not everything. But if you have a choice, don't look for just optician coding, right? Optician person to be helping with the patients. You want to look for positions in prior authorizations. You want to look for positions in insurance, on the insurance side, like Aetna or Blue Cross Blue Shield, where they have claims reviewer, right? Where you're processing claims, not that you're approving surgeries or anything like that, but that you're processing claims. You're getting the claims in from the doctor's office. You're running them through the encoder. The encoder's popping up with what is it? With an edit. An edit means there's something wrong here. Then you're denying the claim, and then you're sending it back to the doctor's office with the, hey, we've denied it because of XYZ, and then they've got to fix it or whatever, and you keep moving. Now, that is going to be using your skill as a coder, because you have to think, okay, there was this edit here, and yes, this is legitimate. Okay, well, here's the rule on this, or they were trying to code this and this, but these two don't go together because I know that because I'm a coder. That's applying your skill and your knowledge, right? So prior authorizations, where you're working for the doctor's office and you're saying, okay, you're looking at the documentation and you're having to use your skill now because you're abstracting diagnosis codes. You're saying that the provider wants to do this procedure. We understand what this procedure is, right? Because we know how to look it up. And so there's that one. There's that claims reviewer position. There's medical billing. Now, medical billing, that you're concentrating on totally. You're working with denials. If you are not doing the coding, you are the last line of defense, right? So if you know that there's supposed to be a modifier on this and there's not, you can actually stop it before it gets sent into the insurance company. You can send it back to that coder if they're working with a coder. If you're working with a doctor, modifier needs to be applied here. Or if you're the one supposed to add it, then you're starting to do coding. If you have to go in as a biller, if you have to go in, you have to change anything because there's no coder on staff and the provider's not going to do it, then you have to do it based on the documentation, and you add a code or you change a code or you make it more specific. That is coding, even though your title says biller. That's how you get experience. For my scribe folks who think scribe is a good idea, scribe is a terrible idea, okay? Because what are you doing as a scribe? You're sitting there doing dictation for that provider in the room with the patient. Yes. Does it give you exposure to what's happening actually in the visit? Yes. But there is no coding. If there is code selection, Guarantee you it's going to be done by the computer assisted coding. It's not going to be done by you as a scribe, because you're just sitting there typing things to make sure that the doctor's got their note and they don't have to write it. You're the one who's writing it. Okay? But the problem with scribe is now you're sticking your neck out. Because if you dictate something wrong and that provider doesn't really look at it, and guess what? They sign off on it. Well, something happens and now they got to look. Okay, well, the scribe did it. So you said you saw this and the doctor approved this, and what's going on here? So again, that's a terrible position to get in. Will it give you exposure to the electronic health record? Sure. But the exposure to the codes is tangential at best. You know, it's not going to be anything that's going to get you sufficient exposure and practice like the other positions I just mentioned. Prior authorizations, working on the insurance side as a claims processor, right? Or billing. Those are alternative positions that can get you somewhere in coding, right? That can get you that transferable skill, right? If you can't get in as a coder somewhere, you know. But also if you're limiting yourself in the fact that you're saying, well, I only want to work remotely. I only want to work remotely, folks. Y'all need to get out of la la land, okay? Because when you're brand new, and this hurts people's feelings, I don't know why. But if you're brand new, to help yourself, because it's going to be a lot. The book is different from the real world, because these doctors are not going to write like the book, right? No matter how much you would love that, right? They're not going to write like the book. So you're going to have to learn to interpret what they're saying and interpret it correctly, because if they're not selecting the codes, or the computer assisted coding's messing it up like it always does, because AI is stupid, that's going to be a problem, right? That's a problem. But if you're using your skill and your knowledge and you're getting that practice in, and you're like, okay, I have to learn this stuff, but you're around other coders, that's what's going to help you. That's why I always tell you guys, and some of you are just so freaking fixated on working remotely. Quit it. Quit trying to be so, oh, I want it my way. No, you can't have it your way. This is not Burger King. This career field is not Burger King. You cannot have it your way. You are going to learn by being around other coders. This stuff is not going to be that hard for you if you are learning with other coders, right? Because you still have to learn the electronic health record, which you didn't learn in school. And even if they do give you like a example electronic health record, it's not going to be anything like any of these big vendors. Epic, Cerner, eClinicalWorks, right? The big boys, okay? Epic, Cerner, eClinicalWorks. These are the ones that they're out there. They're huge. In some corporations, they use them. Others, they don't. Smaller hospitals, they're going to use maybe a package like Epic, but they're going to use a smaller package. So it's not going to be the same Epic as an Epic that's in a big hospital. So that's something else that you have to know too. If you're doing that, that's the thing. You're going to have to learn. And it's easier when you learn in person, because what are you going to do? Be on the chat and be like, oh, I don't understand this. And then the poor person that's having to help you out is having to sit here and go through it with you. They can't get their work done. That's why these organizations don't want to hire new people, because a lot of times new people are not taking the initiative to try to learn on their own, or they're not setting themselves up for success and trying to get into these facilities. And for my East Coast, West Coast people, before you say anything, I know there's a space issue. It's a space problem. Everybody's remote. I get it. Okay. That's something that's completely different. I'm talking about those people that are around facilities that you can be actually in, and you want to still insist that you want to be remote. That's just what I'm saying. Good, Emily. Okay. Crystal says, work in person first. I would have been lost if I didn't with my new job. True. But like I say, wish me luck, Blue. My hospital is going live with Epic next month from 3M. We've done someday in the life training, but we know it's not the same when we go live. Okay, well, you know what? At least it's not Cerner. I'm just saying. um, uh, Katie, I hope I said that right. Hi, Blue. I'm in my first coding role, 4 months in coding internal medicine. Our productivity is 150 per day, and I've heard you say anything over 120 is just data entry. How would you navigate this? Actually, 150 is not that bad. It's not that bad. 150, I've said it's okay if it's a lot on the repetitive side. Now, that's internal medicine. That's not repetitive, okay? So there may be some codes that you're going to see a lot of, and you're going to recognize and okay, so like diabetes, okay, type 2 diabetes, E11.9, but then it gets complicated if they have like high blood sugar, and if they, there's complications and things like that, then you have to use those combination codes and stuff. So in that case, I would just say that at 150 they're saying that this is repetitive. That's what they're saying. So you're going to see a lot of the same things over and over again. So once you get used to it, and I know it's been 4 months, but you're still learning. Okay, you're still learning. There's going to be things that you're going to be able to get through quicker than others. So if you have that capability to be able to decide what you want to do first during your day, some people are very strict and they say, okay, we want you to do this type of coding first, and then you can do whatever it is that you want. For me, I have the clinic, it's all mine. I go for the easier providers early in the morning because that's when like my brain still needs to wake up. By the afternoon, my brain is awake and on fire, and I'm like, okay. So that's when I start working on the more challenging stuff. So I get that done towards the end of the day. And meanwhile, I've already made up all of my productivity that I need to be at in order to relax with the more difficult stuff at the end of the day. So if you are able to navigate that in that way, and adjust how you're managing your workload, then you're okay. If not, just know that 150 is possible, but you're chained to your desk all day long, but if it is repetitive, you'll be able to pick it up. If it is not, and you're having to do a lot of combination codes and a lot of different things, you might want to take your experience and just keep applying for something that is much more reasonable, if that's what you want to do. Like I said, 150 is doable, but it's a little high. At least it's not 210 or 220, something stupid like that. That's data entry. That's just stupid. Brandy says, I do claims follow-up now. I work in Epic at a hospital. I want to apply for E&M's coder, and I've had my CPC since 2021. I'm ready to use it. Well, get on it. Then go ahead and get on it. I've never heard of an E&M coder. I've heard of like clinic coding, and yeah, you can do E&M, and you can do, like minor procedures and major procedures, that kind of thing. So, I mean, I guess different places, have different things. But this reminds me of the other lady that said that I did a show about something, and the lady commented and said that it wasn't right that they made a new coder do E&Ms, and that she thought it was just like special project work, and a new coder shouldn't do E&Ms. And I'm like, no, I was doing E&Ms when I was in my first job as a coder. You don't coddle a coder to keep them from doing it. There's no such thing as, oh, this is a novice coder that they can't do E&M coding. That's just stupid. E&M coding is not hard. I keep telling people it is not hard. And I mean, whether you believe me or not, it is literally not hard, but that kind of reminds me of that. Oh, okay. You're welcome, Katie. So I hope I said your name right. I hope so. Anyway, but yeah, so that's what I would be doing, Brandy. You got all that experience. And I hope you've been practicing on that E&M, because this one lady, she told me, Blue, I've been a risk adjustment coder for 4 years. Can I still be a clinic coder? And I said, Have you been practicing for your E&M? Do you still remember how to do it? Do you still know about your modifiers? Do you still know how to code for procedures? She's like, no, no, and no. I said, well, there's your answer. How are you going to sit there and ask me that question? You haven't been doing your homework. Get to your homework, ma'am. I'm nervous about it. Don't be nervous, because it should be exciting. You should want to do this. You should want to advance. You clearly want to advance. Okay, you brought the practice test from AAPC. Hopefully you're not going to try to do the certified E&M coder. Come on. You are tested in this when you take the CPC. You know, not that many, but you're still tested on E&M coding with the CPC. You know, you don't need a whole credential just to say you know how to code E&Ms. You know, and it's more CEUs, more money you got to spend. I'm just saying, you know. No, just to brush up on it. Good. Okay. If you're just using it to brush up on it, good. And just make sure that you practice it. The best thing that I can recommend for you for the E&Ms is that you understand the table of risk. If you get that table of risk, you're halfway there. Okay. Because table of risk is really where E&M is at now. You know what I mean? Like, what are we doing here? Do we know how to hit each box? You know, if it is one stable chronic illness, or if it is one injury and they have to put on a cast, well, obviously that's going to be a moderate, right? If they're reading the x-ray themselves, if they say, I personally reviewed and this is my interpretation of this x-ray or this whatever, and then they have that documented, then, you know, you have that level 4, you know, whether it is a new patient or an established patient. You got to know the difference between new and established. You got to know the difference between the modifiers as well, too. There's modifier 24, modifier 25, modifier 57, modifier 27 also, but 27 is for like the ER when they come back twice. Right? So a patient gets seen twice in one day. So how does this happen? How do you report 2 E&Ms in one day on 2 visits that are unrelated to each other, right? Say, for instance, the person came in the morning and they were in a car accident, right? And it was like 2:05 in the morning. They were in a car accident and they saw the doctor. They were like, okay, cool, everything's fine. Maybe they set their wrist in a cast because, you know, they had fractured, you know, one of their carpal bones, you know, whatever. And so then they sent them home. Well, then later on, like at 6 o'clock, the patient is saying, oh my gosh, I'm feeling chest pain. So then they go back to the ER. Turns out they're having a heart attack. So this is a completely separate visit. So you would put that E&M for the ER with a 27 modifier on it on that second visit, because this is another E&M visit that happened in the same day in the ER. So that 27 only goes on the ER visits, and the eye doctor visits, they can do that as well. And there's another clinic that can allow for that, but it's not in the outpatient clinic, like 99202 to 99205 or 99211 to 99215. You can't put a 27 modifier on that. It can only go on the ER one. Okay. So knowing the difference in those things, doesn't matter where you're going, it really does help, because you never know what you may be called to do. You may be called to be an E&M coder in the hospital. Okay, does that mean for professional fee coding? Like when they're admitting the patient and that the doctor has to go up to the floor? You see, there's knowing all those different settings that the E&M can apply, and then knowing what the modifiers mean. So practice with that, yes. But if this is really what you want to do, Miss Brandon, you will do it. You will do it. Lady says, I'm a CPCA, certified through AAPC, new to healthcare and working in Eurogen, right? Office, as an office assistant. Required to do authorizations for procedures. I'm doing Practicode. Any advice to help me get hired? Well, I mean, you're doing Practicode, and Practicode, so that I'm clear, Practicode is an educational product. It does not count as work experience, okay? Practicode is what AAPC considers to be what a new coder would do in their first year. It is not considered internship. It is not considered work experience. Some people have tried to do that. You don't do that. You can put Practicode on your resume, but you make sure that you identify this as an educational product, okay? So that way they know that you've been practicing, because Practicode is not multiple choice. You have to look up the answers on your own, So that's just something that you can use. I mean, as long as you have a one-page resume, and as long as you're very specific about what you did as an office assistant, I don't care that you answered phones. Please don't tell me that you answered phones, okay? I don't care. Everybody can answer a phone. But when you're doing this as an office assistant, are you protecting, are you adhering to HIPAA? Absolutely, you're adhering to HIPAA. Are you putting through, are you processing claims? Like, are you sending it off to the billers? Are you having to direct it back to the providers? Are you looking at the documentation to see if the providers have signed off on their notes? And if not, are you querying them? That's what you need to be making sure that you bullet out on your duties there, okay? Because that's very specific in what you're doing. If you ran a report, like a productivity report or something like that, and you said, oh yeah, I ran a QRS report, I don't know what the heck that is. Don't tell me specific titles of reports. Tell me, was this a productivity report for your providers? Was it an RVU generation report for these providers? Was it that you ran their credentials to make sure that they were up to date? Okay. Did you have to keep them up to date with their education? Like they have to report CMEs. Did you have to remind them of that in your duties as an office assistant? So that's the thing that you need to be specific with, on those bullet points. Don't get too wordy, because again, this needs to be only on one page. You only need to go back 10 or 15 years, and that's it. You do not go back further than that, okay? But you put that on there, you're straight to the point, and you make these sentences very, very concise, and that's the best thing that you can do. You list your skills: ICD-10-CM, CPT, Hicks, PICS, medical terminology, anatomy, and pathophysiology. I do not want to see organized and team player smiling face. You put that, that's a guarantee that yours is going into the pile that they're not going to contact you. Guaranteed. Because I would. If I saw that organized team player, I don't care. Those are soft skills. Those do not go on your skills list. So apply, even though they're asking for experience. Apply, because you have had some exposure. What electronic health record did you use in that office? Right? That's what you need to put there too. Did you protect information for the staff? Did you protect information? Because like if you're helping to process payroll, obviously you have to protect their information too. So those are things that need to be on there. Those are key skills that coders, that's the transferable skills that are good for new coders to have. I'm just saying. Hot Flamingo Pink says, I have a question. Okay, what is your sequel question? S06 codes need A, D, or S. So when you use one of these codes as the primary code, do I use one of those letters as the 7th character? Yes. You said 7th code, but I know you mean character. So injury codes are 7 characters long, okay? All injury codes are 7 characters long, right? So it tells you, okay, S06 and then whatever, and then at the end, it's going to let you, that 7th character is going to be A, D, or S. If the patient is still, if this is their first time being seen for treatment, right? Because sometimes they go to the ER and then they go to the ortho. In the case that they go to the ER is going to report that 7th character of A, right? Because it's the first time they're coming in because they just got injured, right? Now, let's say, for instance, they fractured their wrist. Okay, best way to example this. Okay, they fractured their wrist. but they're not really sure. The ER is not really sure that they fractured their wrist, but they said that there's an injury here, that there's a lot of swelling. We're going to put them in a splint, and we're going to send them on over to ortho, and then they can figure it out. Okay. So that's going to be unspecified injury of the wrist, the left wrist. Okay. Because they don't know what it is. They don't know if it's a sprain or not. Okay. But we can still say that it's an injury, right? Don't put on there that it's pain, because it's not pain. They didn't just organically wake up with pain. They did something. Something happened to them. That's how we know we have an injury, right? Something happened to them. So they go over to ortho. Now ortho puts them in the x-ray, and they say, oh, you know what? It is a fracture. So then in ortho, we're going to report that fracture, whatever fracture it is, right, of the wrist. And we're going to put that 7th character of an A. Why? Because even though they've already been seen in the ER, we still don't know what it is until they got to ortho. Ortho is a specialty. And so they're going to be able to spot these fractures right away. Okay, so we've got a fracture here. This is the first time they're being seen, or this is an active treatment of this fracture. So they're going to set this patient in a cast, send him on his way. A couple weeks later, they say, okay, come back, and we're going to check you out, make sure that you're all right. Well, it's not 2 weeks later. It's about 3 days later, and they say something is wrong. Something is wrong with my wrist. It doesn't feel right, and it really hurts now, even though it's still in the cast. So they take another x-ray, and this bone has slipped out of place. So now this is still not on the healing side, right? It's still not healing. This fracture is not healing. So because this fracture is not healing, now this doctor says, you know what, we're gonna have to take it up to the OR. So now we're going to still report this fracture of this wrist with an A, because this is not in the healing phase yet, because we still have to send him to the OR. So the doctor goes and sends the patient to the OR early the next morning, right? Within the time, right? And they've been cleared out, and they don't have anything in their system, so they can have this surgery. They can go under anesthesia. So now they do the surgery, they put the pins in there, and everything's okay. So they say, okay, come back in a couple of weeks, and we'll see how everything's going. So the patient comes back 2 weeks later, and they take another x-ray, and they say, you know what, now we're healing nicely. The fracture is staying reduced, it's staying where it's supposed to be, all the pins are in place, everything looks good. We're going to plan for pin removal in a little bit, but not on this visit. But this, you're okay. Just continue on with what you're doing, and resting and things like that. So in that case, on that visit, that's going to be where we change that 7th character of that fracture code to a D, because we are no longer in the active treatment. We're not actively treating the patient, because now this patient is in the healing phase. Now, when they go in and they say, okay, well, we're going to go ahead and change your cast out while you're here, that's still a subsequent visit. That's still not active treatment, because remember, the fracture's still reduced. It's still fine, right? But we're just changing the cast. So this is going to be that subsequent treatment. So this is when we say that this patient is in the healing phase. Okay? So that's how we can tell the difference. Now, patient comes back, everything's all cool, and it's out of the 90-day global period. The cast is completely off. Everything's fine. And they say, okay, if you have any concerns, then you come back to us. 6 months later, this patient comes back and says, you know what? My wrist, it feels really stiff, and it's been feeling really stiff since I broke my wrist. You know, what's going on here? They look at it under the x-ray, and they say, you know what? You have post-traumatic osteoarthritis of the wrist because of the fracture, because it's in the same area as the fracture. So the doctor documents post-traumatic osteoarthritis of the wrist due to the fracture that they had of the wrist, right? And so then, right, we're going to report that post-traumatic osteoarthritis, right? Then we're going to report the fracture code for that, with that S, right? The S code, the fracture code, and then the 7th character is going to be S. Why? Because we're saying that this post-traumatic osteoarthritis, that this is related to the fracture. And that 7th character is going to be S. That's sequela. Because even though this happened 6 months ago, this doctor is putting this injury together with this manifestation. That manifestation is that post-traumatic osteoarthritis. Now, sometimes it's not post-traumatic osteoarthritis. Sometimes it's just pain. There's no arthritis there, but it's just painful. So in that case, you report pain, the pain in the wrist code, right? The left or right. And then you would code for that fracture code with that S for sequela. Because this says that that pain is related to that fracture. So that's how you know how to distinguish between those. But let's go back. Let's say that that same patient who fractured, let's just say it's a clear fracture. It's a clear fracture of that wrist. They present to the ER. They were in a car accident. They say, oh, you know what? You fractured your wrist, so we're going to go ahead and set you in a cast. We're going to go ahead and set you in a cast. So that the ER sets the patient in a cast because they're not going to be able to go to ortho for like 4 days, and they don't want to leave them in a splint. They want to go ahead and treat it now. So they say, okay, in 4 days, you're going to go over to ortho and follow up with them. Okay, cool. But they put them in a cast already. In that case, the ER would report the closed treatment, right? Let's just say they had to manipulate it. So closed reduction with manipulation of the wrist fracture with the 54 modifier, with the 54 modifier on it, because this says that fracture code, that fracture treatment, CPT code, that's going to get that 54 modifier on it. It's 2 something something. But it's going to get the 54 modifier plus LT or RT, whichever side got fractured. Because this is going to say that the ER, this is that fracture treatment code for the CPT code, that has a 90-day global period on it. This is saying that the ER is the one who performed the surgery or the closed treatment, right, of this fracture. So when that same patient goes over to ortho now, okay, because they're in a full-on cast, everything is good to go. So they get over to ortho, and ortho says, you know what? They did a good job on this casting, and we're going to go ahead and leave it for right now, because instead of like taking you out of it and things like that, it looks really good. We're just going to maintain it for another couple of weeks. In this case, ortho is going to report that same procedure code as the ER did, but instead of a 54, they're going to report a 55 modifier, because this says that ortho is taking care of the post-operative care. Now, of course, there needs to be documentation from the ER that says we applied the cast today. Ortho is going to take over for the aftercare, because they're not going to come back to the OR for the aftercare. And there's a few other things that need to be said, but for the purposes of just the explanation, that's what they're going to document. And so ortho is going to take over, and so they're going to report that same procedure code, right, for that closed treatment. And then they're going to report a 55, because it says that this is the post-operative care only. They did not place the initial cast, but they are going to get a percentage of the funds from that treatment, because they are taking care of the aftercare part. And in that case, that closed treatment fracture CPT code is being reported with a 55. That diagnosis code is going to be that fracture code with a D, not an A. The D for subsequent, because the patient's already in the healing phase. They've been seen for their initial treatment and their active treatment elsewhere. They are here for their subsequent healing treatment. So that's where we're going to have that D for that 7th character for when they see ortho. And ortho says that we're not going to change this cast for right now. Just leave the cast the way it is, because that's how we're going to take care of this patient. And then it goes on, right? It goes on however long for the 90 days, right? and that's how long it is, that they have them for. So yes, that's how you know the difference. So you see, it's not that hard. It's not that hard. And if this stuff went over your head, just rewatch the video again. But yes, I think that's a really good breakdown of the differences in the fractures. But that's the kind of stuff I love explaining, because to me it's fun to get those kind of situations and be like, oh, okay, that's where we get those. But You got to know those things when you're reporting procedures. And then you got to understand about those other things for E&M separately. Okay, just so we know. Hopefully that helped. Hot flamingo, hot pink flamingo, or hot flamingo pink. Lady says, okay, thank you. Hot flamingo pink says this payment has a terminal diagnosis, and the traumatic injury was caused by a pew pew. Okay. About 20 years ago. So what 7th character do you use? If it is pain, you're telling me it's pain. Is it pain? And then, or is it a scar? If it's a painful scar, there's a code for painful scar. But if it's just pain, wherever it is, say for instance, it's in their arm. They got pain in their upper arm, okay, and then you're gonna code for if they say that it is related, they gotta say that it's related to that pew pew, right? Then that's when you're gonna select the code for that, okay? And I think it's gonna go open. There's an open wound code or something like that. I don't know. I have to look. But there's a code. But I know the external cause code you're gonna report is the pew pew with the S, okay, for the external cause code. So whatever the injury was, okay, whether it was a fracture, right, that they got from the pew pew, right, or whatever, just go through and type in whatever it is into your encoder or look it up in the book, so that way you can get it that way. But yes, that would be sequela. If they're feeling pain, even though it was 20 years ago, because of the self-inflicted pew pew wound, right? You put whatever the pew pew wound is, of course, but you put that pain first, then the pew pew, and then the external cause code with the 7th character of S. And that's how you do it. Not payment, the patient has a terminal diagnosis. Okay, the insurance carrier rejected the code and we used the S character. Well, did you put the manifestation with it, like the pain and then the pew pew wound one and then the external cause code? The patient, not payment. Okay. You're welcome. Okay, so hopefully that makes sense, because it makes sense to me, but I don't know. Lotus says, hi Blue, so glad you are doing this live tonight. I rewatched your old live video this morning. Oh, cool. Good. Alrighty. So how long have I been on? An hour and 20. Okay, not bad. All right, so hopefully that helps. Little impromptu lesson on injuries. So I need to do one. I need to do I need to put together a slide deck for that. I need to. I'll probably do it for my Patreons. I know I need to do one for like when they're doing what is it? The pre-op appointments. I know I need to do one for that one, because a lot of people get confused with those pre-op appointments. They still want to report the 7th character of D, and I'm like, no, they're coming in for a pre-op, and this is active treatment because they are not in the healing phase yet. You do not report a 7th character of D if you are reporting a pre-op code, the Z01818. You do not report the 7th character of D when you're reporting the pre-op code, because obviously this patient is not healed. They need to go in for surgery. How's that going to look? You report a D and then you report an A, or you report a D and a D. Come on, man. No. You know. All right. So that's all I got for tonight. Anybody else got anything before I wrap it up? Because I know on my East Coast people, it's already after 10 o'clock. So all right. Well, if y'all have any suggestions for shows, let me know, because I still got to film for tomorrow. I won't do that tonight. I'll do it tomorrow. I just got in later today, so that was the problem. Anyway, guys, I will go ahead and wrap this one up. Thank you guys so much for being a great audience. Thank you for joining me. If this video helped you, please like, subscribe, and share, and I'll see y'all next time. Bye.